Yep. ठीक है मतलब समझाना इम्पोर्टेंट है बाकी प्रेजेंटेशन कैसे भी अच्छा फिर इसे डिस्क्राइब किया मेरी
Hi, good morning. I'm Sonali Singh, and I'm associated with PharmaCat. So, वो दिखा रहे हैं. Hi, good morning. I'm Sonali Singh, and I'm associated with PharmaCat, and I would be discussing the topic antihypertensive and antiarrhythmic MCQs today. So let's begin. Okay, so let's begin with our today's topic, that is antihypertensive and antiarrhythmic. So before going to the MCQs, let us have a look at the classification of these drugs. So what you will find majorly is majority of your MCQs will lie in this classification itself. So let us look at the classification. So antihypertensive have diuretics, they have ACE inhibitors, they have sympathetic inhibitors, that is beta blockers and other adrenergic blockers and central sympatholytics. They will also include direct renin inhibitors like aliskiren. Other major class are calcium channel blockers and vasodilators. So let's begin with the MCQ section and solve the MCQ with respect to this classification and the mechanisms. So to begin with, which of the following drugs is a selective beta blocker antihypertensive drug? So when you see the classification of beta blockers, the answer here would be metoprolol. Why? Because as you see the classification, non-selective beta blockers will include drugs like propranolol and sotalol and timolol, whereas cardioselective beta blockers will have metoprolol, bisoprolol and atenolol as the major drugs, out of which metoprolol and bisoprolol are more cardioselective compared to the other drugs, that is atenolol and other in this class. Apart from that, we have alpha plus beta action drugs also. That would include labetalol and carvedilol. So to answer the previous question, it would be metoprolol. So the next question is, clonidine induced rebound hypertension is treated by which of these drugs? So if you read your theories properly, the answer is pentolamine, because as you see, prazosin, terazosin and doxazosin belongs to adrenergic blocker drugs. And phentolamine is given for treating hypertension caused due to clonidine-induced rebound as well as cheese reactions. So the hypertension caused due to these conditions, that is when you suddenly or abruptly stop clonidine, there would be a rebound hypertension. And so phentolamine is given as a choice of drug. Okay. To move with the next beta blocker, having membrane stabilizing activity. So before discussing the answer, what is membrane stabilizing activity? So this membrane stabilizing activity is where the extra action potential is not generated in the membrane. That means your membrane will be very stable and will not generate any other action potential. So when you see the classification of these drugs, the answer here would be propranolol. Reason for the same is propranolol, oxypranolol, and isbutalol are the three drugs which are involved in, which are included in this category of membrane stabilizing activity. So they also claim to have antiarrhythmic action, but of course the doses will differ. So the antiarrhythmic action and membrane stabilizing activity of propranolol will be seen at a significant high dose. So moving with the next is alpha blockers, which are used as antihypertensive drugs. So again, as I said, majority of your MCQs will lie in the classification part itself. So if you know your classification better, there would not be an issue in solving these type of questions. So if you had seen the classification, the alpha blockers had this zosin drug, prazosin, terazosin, and doxazosin. So the answer here would be all, because these are alpha 1 selective blockers and used as antihypertensive drugs. The other in this class would include alfuzosin and tamsulosin. Okay. Moving on with the next question. Which drugs are used as a first line treatment of hypertension? So as we know, hypertension is a situation where there is high blood pressure in your body, and it could be due to any reason. It could be due to high sodium content, and along with sodium, there would be high fluid in the body. Hence, the blood pressure rises. So the first line treatment that is given for a hypertension patient is your diuretic. So in case of mild hypertension, the first line drugs given are diuretics in combination. They can be in combination with other beta blockers like metoprolol. And when the hypertension is a little severe, this treatment is followed by other class of drugs, that is ACE inhibitors and ARBs. So if diuretics was not a part of this question, it would be ACE inhibitors or ARBs as a first line treatment of hypertension. But here it will be diuretics because it is the beginning drug, the first line treatment for mild hypertension. And mild hypertension is in the range between 121 to 139 systolic and 80 to 90 of diastolic blood pressure. Okay, so moving on with the next question. Mechanism of antihypertensive action of clonidine. So let us look at the mechanism of action of clonidine. So if you remember the classification, clonidine was a part of central sympatholytic drug. So clonidine, the answer for the same would be, firstly, if you eliminate the wrong one, The eliminated answers would be A, that is peripheral. As we know, clonidine has a central action. So A and B option will get eliminated because clonidine has a central action. Now, to choose between central, that is option C, central alpha 2 adrenergic agonist, or answer D, central beta adrenergic agonist. So the answer would be C, because clonidine is a partial agonist with high affinity and high intrinsic activity at alpha 2 receptors. And in alpha 2, it specially is a subtype of alpha 2A, which is present in the brain stem. So, again, when you look back to the question, now you realize why central sympatholite. Why it is a central alpha 2 adrenergic agonist, because these alpha 2A subtype receptors are present in the brain stem. So the action will be centrally seen. Okay. So this is a very straightforward question, which we might have heard so many times. Like, which antihypertensive drug that has hypertrichosis as an ADR? So firstly, to discuss what is hypertrichosis. So hypertrichosis is a condition where there is excessive growth of hair. So if you know the answer, it cannot be methyl dopa, it is not propranolol, and neither it is diltiazem. Answer here is minoxidil. So this is a very prominent adverse reaction of minoxidil, which is seen when it is used as antihypertensive. That is, the adverse reaction of hypertrichosis is seen. Hence, we utilized this adverse reaction and we started preparing the oral minoxidil or topical minoxidil for hair growth purpose. So minoxidil increases growth of body hair when you apply it topically or when you take it orally, and it is promotes the growth in male pattern baldness and alopecia areata. Okay, so let's move on to the next drug. The next MCQ says antihypertensive drug which relaxes both arterial and venous vascular smooth muscle. So in the classification section, we also saw a classification of vasodilators. So vasodilators are also used as antihypertensive drugs. So under vasodilation, there were two classes. One was the drugs that were relaxing only the arterial smooth muscle, and the other was both arterial and venous vascular smooth muscle. So firstly, if you look here, again we can eliminate the wrong one. That is minoxidil. If you know, it does not belong to vasodilator. And the same goes with propranolol. It belongs to beta blocker class and does not belong to vasodilator. So we have two options left with us, that is A and B, hydralazine and sodium nitroprusside. So to be specific, the answer here would be sodium nitroprusside, because if you see the classification, arteriolar vasodilators will include hydralazine, minoxidil, and diazoxide as the drug, whereas arteriolar with venous vasodilatory properties, you have sodium nitroprusside as the drug. Okay, coming on to the next question, the class of antihypertensive which is useful in the management of low-renin hypertension and can be given as a monotherapy. Firstly, to discuss what is low-renin hypertension. If you remember the renin-angiotensin-aldosterone system, when there is less fluid in the body, renin is activated. So renin further gives rise to a cascade of events. Like renin further activates your angiotensinogen, then comes the ACE enzyme, the angiotensin converting enzyme, and further the process goes on. So in that cascade of events, we can make out that renin was increased in a good amount, and hence we have drugs like renin blockers, or we have ACE inhibitors or ARBs, that is angiotensin receptor blockers. But here in this condition, the hypertension is not due to renin, but it is due to low renin. That is, even when renin is secreted in a very low concentration compared to the normal situations, there is hypertension seen. So there are various reasons behind it. So what happens is, suppose if your renin is less and aldosterone levels are high. So aldosterone has a property of regaining back the sodium or reabsorbing back the sodium. So sometimes what happens is your body becomes sensitive to sodium, and in that case, even if low sodium or even if there is normal proportion of aldosterone in body, low renin would be secreted, and this also might cause hypertension. Okay, so the answer here would be calcium channel blockers. So why calcium channel blockers? So if you see, if we give ACE inhibitors, it would not affect your renin levels. It won't affect your renin levels because ACE inhibitors would stop the ACE enzyme from converting angiotensin 1 to angiotensin 2. And similarly, if you see loop diuretics would only act on the absorption of your sodium and on your water retention. But if you see the calcium channel blockers, they promote blood vessel relaxation. And as we know, blood vessel relaxation would also aid in relieving your hypertension to a normal levels of blood pressure. So when the RAS works as expected, high levels of renin increase your blood pressure. But with low renin hypertension, what happens is you experience high blood pressure even with low or typical renin levels. In this condition, you may not even have enough renin to help set off the process that controls your blood pressure. So, hence, if we can see, renin is a very important factor in controlling your blood pressure. Hence, renin concentration needs to be appropriate in the cells. But you see, if there is no renin or if there is less renin, there is a loss of control on blood pressure, and hence it may cause low renin hypertension and situations like such. So I hope the previous MCQ was clear. Let us have a look at the next one. So antihypertensive vasodilators that can be most readily used for chronic treatment. So again, we come back to the vasodilator classification. So if you see, vasodilators has two parts, arteriolar and arteriolar plus venous. So arteriolar had hydralazine and minoxidil and diazoxide as the drug. And arteriolar plus venous had sodium nitroprusside as a part of drug. So the answer here would be both B and C. Now, why B and C? B is hydralazine and C is minoxidil. And why not sodium nitroprusside? It is also a vasodilator. But if you see the actions of sodium nitroprusside, it is very quick in action. Like within 2 to 4 minutes, it will give you action, and it will decrease your blood pressure to such a low extent that it may also cause severe hypotension, which is not desired for chronic use. Whereas if you see hydralazine and minoxidil, it belongs to arteriolar vasodilators, and it is found to be safer than sodium nitroprusside for chronic use. So since sodium nitroprusside has its action on both arteriolar and venous blood pressure, it would decrease the blood pressure to a greater extent compared to hydralazine and minoxidil. Hence, it is not safe for the chronic use. So I hope these first 10 MCQs are clear, and we can move forward with the next set of MCQs. So this was the anti-hypertensive MCQs. Let us look at the next set, that is antiarrhythmic. So again, as I said, majority of your MCQs will lie in this part itself. Which drug belongs to which class or has what action? So let us look at the drugs once. So if you see class 1 drug of antiarrhythmic, so first of all, classification of antiarrhythmic is a bit different when you compare to other classifications or other few diseases or conditions. Here, the classes are given specific class number, that is 1, 2, 3, 4, and within class there are subclasses like 1A, 1B, 1C. And you cannot interchange these classes because it is named as per the guidelines. Okay, so let us have a look. So class 1 of antiarrhythmic drugs belongs to sodium channel blockers. So 1A, the action of 1A would be to prolong the repolarization phase. Okay, and the drugs that belong to this class is quinidine, procainamide, and diisopyramide. When you talk about class 1B, there is it produces short repolarization. Okay, and the drugs that belong here would be lidocaine, mexiletine, procainide, and phenytoin. And the class 1C has little effects on repolarization, and the drugs that belong to this class would be flecainide, encainide, and propafenol. So if you see, there is no proper way to remember these drugs. For example, you can remember beta blockers as OLOL, but these drugs are quite undifferentiated with their terminology part. Okay, moving on to the next class, that is class 2 of antiarrhythmic. So it has the class 2 is beta adrenergic blockers. That is your propranolol and esmolol, the beta blockers that we know. Class 3 would further have prolonged repolarization of potassium channel blockers. So this will include drugs like sotalol and amiodarone. And class 4 has calcium channel blockers as the drug, that is verapamil and diltiazem. So let us look at the MCQ part. To begin with, the first MCQ, it is, which of the following statement is correct? So these type of questions are a bit tricky. So you need to read them very carefully. To begin with, option A says digoxin increases action of quinidine due to inhibition of its excretion. Option B says digoxin increases action of quinidine due to increasing its metabolism. Option C says quinidine increases action of digoxin due to inhibition of its excretion. And option D says quinidine decreases the action of digoxin due to increasing its metabolism. So if you have read the interaction part of quinidine and digoxin, the answer here is quinidine increases action of digoxin due to inhibition of its excretion. So let us look why it does so. So the reason behind it, quinidine is a PGP pump inhibitor, and it acts as a renal tubule. So normally this P-glycoprotein pump at the renal tubule is responsible for renal tubular secretion, and hence it increases the excretion of drugs like digoxin. But if you see quinidine, it is the inhibitor of the pump. So quinidine will inhibit this pump, and thereby it decreases the excretion of digoxin, and hence digoxin is not excreted from the body and hence leads to toxicity. Hence, when you administer drugs like quinidine and digoxin together, you need to be really very careful. The other reason for the same is quinidine also displaces digoxin from its protein-bound form and increases its level in the blood or the plasma. Thus, the toxicity of digoxin increases. I hope this was clear. Let's move on to the next. So, choose the wrong combination of disorder and the drug of choice. So, let's have a look at the options. So, the first option is congestive heart failure and digoxin. Next says wolf-parkinson-white syndrome, and the drug is amiodarone. Option C says type 2 hypercholesterolemia, and the drug of choice is statin. And option D says supraventricular tachycardia, and the drug of choice is phenytoin. So, if you know your drugs and the classification well, the answer here is phenytoin. That is option D, supraventricular tachycardia, and the drug is phenytoin. So, as you know, congestive heart failure has digoxin as a very major drug that is given. Similarly, wolf-parkinson-white syndrome has amiodarone as a drug of choice due to its action and due to its longer duration of action. Type 2 hypercholesterolemia have statins like lovastatin, simvastatin, rosuvastatin, etc. So why is it option D, which is the incorrect combination or the wrong combination? So as we know, phenytoin is often described as non-specific sodium channel blockers and targets almost all voltage-gated sodium channel subtypes. So it belongs to class 1B of your antiarrhythmic drugs, if you remember. But phenytoin is not a choice of drug because it has many side effects, firstly. And secondly, phenytoin's major use is to control the seizures or, psychomotor seizures in treatment of epilepsy is treated using phenytoin. But it is not a safer choice of drug for arrhythmia. But since it has sodium channel blocking properties, it is classified in class 1B of arrhythmia. Also, if you look at supraventricular tachycardia, adenosine is the choice of drug which we use for this condition and not phenytoin. Okay, so let's have a look at the next MCQ, which says all of the following drugs, all of the following mechanisms are responsible for arrhythmias, except option A says ectopic pacemaker activity, option B says re-entry, option C says delayed after depolarization, and option D says heart failure. So if you know your arrhythmia well, the major mechanisms that are responsible for arrhythmias include ectopic pacemaker activity. That is, when your AV node and Purkinje fibers, bundle of leads, these are ectopic pacemakers. That is, other than your main pacemaker. The main pacemaker of heart is SA node. So when your SA node has some problem in functioning, these are the other ectopic pacemakers which can generate impulse. But when they start generating impulse, in spite of SA node being able to generate impulse, there are many impulse generated and which leads to problems like arrhythmia due to many action potential generation. So this is one of the reasons. the next reason is re-entry. So what is re-entry? Re-entry of impulse. That means once an action potential or an impulse has been generated, it re-enters. Firstly, it enters your ventricles. It goes to your artery, the aurium, and then it comes back again to the ventricle. So that is a re-entry of your impulse. So impulse is not able to get out at one go. So due to this re-entry, the impulse still remains in your tissues, and hence the action potential keeps on generating. So this is another possible reason for arrhythmia. And the next reason you see here is delayed after depolarization. So if you remember, what does delayed after depolarization mean? It means that there is an impulse generated just before the second action potential. That means first an action potential is generated, and when a second action potential is going to be generated, just before that, there is a small action potential generated. That is called delayed after depolarization. So when you see all these three are the possible mechanisms responsible for arrhythmia. So what is left here is option D, that is heart failure. So let's see why is this not responsible for your mechanism of arrhythmia. So as rightly said, heart block but not heart failure is responsible for arrhythmia. If there is blockade in your heart, or if there is AV blockade, it is then that impulse keeps on regenerating, or the action potential keeps on taking a rise, and hence there is generation of arrhythmia. But heart failure is not the reason for arrhythmia. It may happen that arrhythmia becomes a reason of heart failure. Okay. So the next is the period of time in which another action potential cannot be initiated is called A, phase 4 depolarization, B, action potential duration, C, effective refractory period, or it's D, maximum diastolic potential. So if you remember your action potential, you see the distance or the time between the depolarization and the repolarization phase, that is between a single action potential. It is called effective refractory period, and it is this time when no other action potential can be generated, and hence it's a mechanism to stop generation of another action potential. So during this period, depolarization on adjacent cardiac muscles do not produce a new depolarization in the current cell, as it has to refract back to the phase 4, that is starting from your phase 0, entering phase 1, phase 2, phase 3, and then getting back to phase 4. Until this time, no new action potential can be generated. Okay. So the adjacent muscle will also not have any generation of cardiac action potential. So ERP, that is the effective refractory period, is a protective mechanism, and it keeps the heart rate in check, and it prevents conditions like arrhythmias and helps coordinate the muscle contraction. So ERP, that is the effective refractory period, is often used as a mechanism to control arrhythmia as well. There are certain drugs which increases your ERP, and hence they ensure that no next action potential is generated very soon. I hope I'm clear with this. So the next MCQ is, which unique antiarrhythmic drug produces short-lived therapeutic benefit and adverse effects? So short-lived here means within seconds. So if you see the antiarrhythmic, verapamil belongs to calcium channel blockers and diltiazem also belongs to the same class. Here, magnesium is given as an add-on therapy when no other drug is working or in a very severe condition. But here, a drug called adenosine. Adenosine is a drug that is having action of approximately 30 seconds with a T-half of approximately 10 seconds. It is very fast acting and it is very, very effective in more than 90% episodes of PSVT, that is paroxysmal supraventricular tachycardia. Whereas you see verapamil and diltiazem, they're calcium channel blockers, they have longer duration, and when you compare the benefits of adenosine with the above two drugs, adenosine will have lesser side effects compared to verapamil and diltiazem and have greater therapeutic benefits. So moving on with the next question, which of the antiarrhythmic drugs belongs to class 4 antiarrhythmic agents? So again, as I said, the classification is your base. You need to know your classification well in order to solve MCQs like this. This is a one-step answer. You don't have to think for this if you know your classifications well. So if you remember, enkinite belongs to class 1. Sotalol belongs to class 3 and propranolol belongs to beta blocker drug, that is class 2. So the answer here is verapamil, which belongs to class 4, and class 4 is your calcium channel blocker. So in order to remember which drugs belong to which class, that is 1, 2, 3 or 4, you need to also remember that what are the mechanisms or what are the class of these drugs. For example, class 1 is sodium channel blocker. Class 2 is your beta blockers. Class 3 has potassium related activities, and class 4 is your calcium channel blocker. Okay, so class 4 is calcium channel blockers, and calcium channel blockers has verapamil as a class of drugs in it. Okay, so here we see the rest classification, that is verapamil belongs to class 4, propranolol belongs to class 2, sotalol belongs to class 3, and enkinoid belongs to class 1, and to be specific, 1C. Let's move on to the next MCQ for today, that is the drug which is indicated for wolf-parkinson-white syndrome. So firstly, let's discuss what is this syndrome, wolf-parkinson-white syndrome. So in earlier MCQ, we saw re-entry as a possible mechanism for arrhythmia. It is this re-entry which we name as wolf-parkinson-white syndrome. Okay, so if you see, lidocaine belongs to class 1, nifedipine is a calcium channel blocker and belongs to class 4, and diisopyramide is also a drug, but the drug of choice here is amiodarone. Why? Amiodarone is a drug of choice as it is a re-entry type of arrhythmia, and amiodarone is very good with handling these type of arrhythmias. Amiodarone also has a prolonged duration of action. Hence, it will relieve your arrhythmia for a longer duration compared to other drugs. Okay, so this was the answer for MCQ 17. Okay, moving on to the next question. This would be interesting. So question 18 says, a dog you are treating suddenly develops ventricular tachycardia. Tachycardia is increase in your heart rate. Okay. You attempt to convert the arrhythmia with IV lidocaine, which fails to produce any change in the heart rhythm. Which of the following is also an antiarrhythmic drug that could be next used for the treatment of ventricular tachycardia? So, these types of questions are a bit tricky and you need to think on it. Okay. So, there was a dog, you treated the dog, it suddenly developed ventricular tachycardia. The first drug you used was lidocaine, but lidocaine did not produce any change in the heart rhythm. So, let's see which drug was useful in ventricular tachycardia. The answer here is procainamide. Why? Because procainamide also belongs to the class of sodium channel blockers and it also has a useful effect in ventricular tachycardia like situations. So after lidocaine, if you choose a drug for ventricular tachycardia, the drug of choice is procainamide. Not digoxin, not diltiazem, and not femobendin as well. Okay. I hope this is clear. Okay, moving on to the next MCQ. So example of a potassium channel blocker drug is, so if you remember your classification again, potassium channel blockers included the drugs like amiodarone, dronedarone, dofetilide, and ibutylide. So the answer here is both A and B. It is a simple one-step answer if you remember your classification well. That is dofetilide and ibutylide are the two potassium channel blocker drugs which are used for treating arrhythmia. These drugs are comparatively newer when you compare them to amiodarone and dronedarone. Okay, so this was based on the simple classification. Okay, so let's look at the last MCQ for the day. The drugs which have fast association and fast dissociation kinetics towards the sodium channels are option A is class 1A, option B is class 1B, option C is class 1C, and option D is class 3. So firstly, if you know the classification well again, you know that class 1 belongs to sodium channel blockers. Okay, so D will be excluded from your answer because class 3 were potassium channel blockers. And we are here looking for sodium channel drugs. So class 1A, class 1B, and class 1C are your three options left. Now, if you know the mechanisms of these three drugs properly, you will know that the answer here is class 1B. Now, why is this so? Let's look at the reason. So class 1B has fast association and dissociation. So what does this association and dissociation mean? So if you know kinetics of your receptors, these drugs will associate very fast with your receptors and dissociate also very fast with these receptors. So hence fast association and fast dissociation is seen with class 1B drugs. These class 1B drugs also have shortened phase 3 repolarization and therefore they shorten the action potential duration. Okay. When you look at class 1C drugs, they have slow association and slow dissociation. That means they will associate slowly and as well as dissociate slowly from the sodium channels. Okay. Okay, and these drugs have no additional action, or they do not show or they show little effect on the action potential duration. That means it is not like class 1B, which has which shortens the action potential duration. It shows a very little effect on the APD. Okay, and class 1A is when intermediate, which has intermediate rate of association and dissociation from the sodium channel. Okay, and class 1A drugs also have additional class 3 activity by blocking potassium channels, which further delays your repolarization. So what we can conclude based on these class 1 drugs is they increase the action potential duration. Only you need to remember is which class has faster association dissociation, slow association dissociation, or intermediate association of dissociation rate from the sodium channel. Okay. And once you know those mechanisms in detail, these MCQs become very easy for you to solve. So this was the last MCQ for the day. I would like to thank you for attending the session and I thank you on behalf of Team PharmaCAD, and I hope you understood the MCQs well.